Today I'm going to present you an interesting case report about epileptic seizures in a pediatric patient with vein of Galen aneurysmal malformation and obstructive hydrocephalus. This is a very rare case report with the colleagues of Germany. So today's agenda will include of the presentation introduction, case presentation, discussion, a conclusion, and I will show you my references. So the vein of Galen aneurysmal malformation, also known with the abbreviation VGAM, is a rare congenital arteriovenous fistula in which one of multiple choroidal or thalamic feeders shut into the median prosencephalic vein of Markovsky and dilated pathologically, which causes compression and complications such as hydrocephalus, congestive heart failure, and seizures. It is a very rare abnormality occurring in 1 in 25,000 births. The lesion can be diagnosed via antenatal and neonatal imaging such as MRI angiography, ultrasound, and Doppler. The treatment includes surgery, medication, and endovascular embolization. With the endovascular embolization can be divided into transarterial and transvenous. The transarterial embolization remains the gold standard in pediatric patients, and later on in my presentation I will tell you when should we use the transvenous embolization approach. Obstructive hydrocephalus is a common complication in patients with VGAM, presenting with enlarged ventricles and cranium due to the dilated vein of Markovsky compressing the aqueductus sylvius, which blocks the flow of the liquor. The preferred treatment method for obstructive hydrocephalus in such cases when embolization of the VGAM cannot be performed or is insufficient by itself in the current situation in neonates and infants is the endoscopic third ventriculostomy, which is associated with less severe and more infrequent long-term complications when compared to the alternative of ventriculoperitoneal shunt. So in the current situation, and most of the times, we should prefer the endoscopic third ventriculostomy because it's associated with a lower risk of complications. A 6-year-old male has presented to the emergency room with a severe episode of convulsive status epilepticus with tonic-clonic seizures. The child had a clinical history of seizure and had been diagnosed with epilepsy for nearly 2 years, alongside a rare combination of previously treated congenital comorbidities like VGAM, obstructive hydrocephalus. The patient had no intellectual pathologies and no neurological deficits reporting to that point. The clinical history was very intense. The patient was born with a high Bicêtre score of 19, indicating a slight subclinical function of his vital systems, with no significant clinical manifestation. The obstructive hydrocephalus was diagnosed upon birth based on the physical examination and because they saw a large cranium, and later on it was confirmed by the MRI imaging. The same MRI revealed the presence of an aneurysmal malformation of a relatively large size in the medial region of the presencephalon. Here we can see the very large ventricles. The actual ventricles are large, and we can see the dilated vein of Galen. Here in red is the aneurysmal malformation. Here there are more planes. Here we can see again the dilated vein of Markovsky and the enlarged ventricles. With red are the ventricles and with blue is the aneurysmal malformation. An appointment MRI angiography confirmed that the location of the malformation was in the median prosencephalic vein of Markovsky and revealed that the type of the fistula to be choroidal, with a network of multiple posterior choroidal and thalamic arteries draining directly into the anterior segment of the vein and dilating it. Thus, the formation confirmed that the hydrocephalus was a secondary condition as a complication due to that malformation. Here you can see an MRI angiography, which shows again the aneurysmal malformation. The patients wanted the hydrocephalus to be treated first by a pediatric neurosurgeon. An endoscopic third ventriculostomy was chosen as the treatment approach due to its better, as I said, long-term prognosis and the nature of the obstruction. The intervention was performed at the age of 4 months under general anesthesia, and it was successful. No complications were observed. Over the course of the following month, more regular checkups registered the presence of a short-term postoperative fever, which was treated with acetaminophen, 15 milligrams orally, and resolved after the first week. The neurosurgeon consulted the patient's parents, and he emphasized on the importance of treating of the VGAM in the near future. However, the patient decided not to embolize it at this point due to their financial concerns and economic problems. When the patient was 40 years old, he had no neurological deficit, he had normal intellectual physiological development. The VGAM malformation was treated via partial endovascular transarterial embolization with onyx. A good result was achieved actually, with most of the features, especially the posterior choroidal ones, have been obliterated completely. On the postoperative angiography, there were no intra or postoperative complications to be mentioned, and a satisfactory neurological outcome was reported at the range of 6 months follow-up period. 8 months after the embolization, the seizures started occurring, and no one actually didn't know why. The patient was diagnosed with an epilepsy after a consultation with a neurologist, and he was treated with the condition with 150 milligrams of valproate on orally daily. We concluded that the epilepsy was idiopathic and it was not associated with the VGAM embolization as a complication or something else, as we could not establish a clear correlation between the pathology and the precision of surgery. So here we can see the postoperative MRI angiography of the patient. On the blue, you can see the transarterial catheter, and with the red arrow, you can see the partial endovascular embolization of the aneurysmal malformation. Again, here you can see with the red arrows the post-embolization MRI angiography. For a period of 1.5 years, the patient condition was satisfactorily managed. 3 weeks prior to the emergency room visit, the patient decided to lower the dosage of the valproate. I want to point here, the doctors did not say for them to lower the dosage. The parents, on their own mind, they decided to lower the dosage, which is a very big mistake. Which at this point had reached 200 milligrams daily orally in accordance with the patient's weight. To 100 grams, so they lowered it double because of the patient's complaints of somnolence. He wanted to sleep a lot, which can be an adverse side effect. Shortly thereafter, the severe seizure had brought the patient to the ER. At the ER, they were suspicious that the status of epilepticus was caused by an ischemic stroke. That possibility was dismissed upon the patient's mention of the lower valproic acid dosage and the absence of clinical manifestation characterizing cerebral ischemia, such as dysarthria, muscle weakness, and neurological deficits. The patient exhibited signs of being in a post-psychotic state. He was dizzy, disoriented, and complained of a headache, but after half an hour, he returned to his regular state of consciousness with normal reflexes, awareness, and satisfactory level of motor coordination. After administering a dosage of 2 milligrams of valproate orally, a neurologist emphasized the importance of the patient being treated with the proper dosage of the medication. Afterward, the patient was discharged from the ER with the recommendation to be regularly monitored for long-term complications following the previous interventions of the embolization. So the discussion, the vein of Galen aneurysmal malformation is a rare type of congenital arteriovenous fistula developing between the 6th and 11th gestational week, in which one of multiple posterior choroidal or thalamic arteries shunt blood directly into the prosencephalic vein of Markovsky, which is the embryonic precursor of the great cerebral vein, or in other names, the vein of Galen. And thus, in this way, they pathologically dilate it. The incidence of the lesion is estimated to be around 1 in 10,000 and 25,000 births, forming up to 30% of all congenital vascular abnormalities in pediatric patients. Diagnosis of the abnormality can be either made by fetal MRI, ultrasonography, Doppler, or MRI angiography, or neonatal through the use of MRI angiography, CT scan, or transfontanelle ultrasound, with both MRI both prenatal and postnatal being the gold standard. Differential diagnosis of the lesion includes cavum verge cyst and other intracranial cysts, among which cystic masses of the subarachnoid matter, pineal gland, the choroidal plexus, cerebral parenchyma, and the pineal gland. However, all of these pathologies exhibit no blood flow with color Doppler. So when you're not sure if this pathology is a cyst or this aneurysmal malformation, the gold standard, so we can differentiate between the diagnosis, should be the color Doppler, because they don't exhibit, the cysts don't exhibit blood flow in the Doppler imaging. The malformation can be differentiated as either mural, in which single or multiple arteriovenous fistulas shut into the inferolateral margin of the low of the prosencephalic vein of Markovsky, or choroidal, in which multiple posterior choroidal and thalamic feeders shunt into the anterior segment of the vein. It should be noted that the VGAM malformation is different from the vein of Galen aneurysmal dilation, in which there is anterior venous fistula drained into the true cerebral vein, rather into the embryonic precursor. Endovascular embolization is regarded as the safest and most appropriate option for the treatment of neonates and infants diagnosed with VGAM, especially when the lesion is choroidal, although there are significant preoperative and postoperative complications to be taken into account, such as cerebral hemorrhages, hematomas, ischemia, hydrocephalus, and overall poor neurological outcomes. The embolization itself can be achieved by transarterial or transvenous approach, with the former one being preferred for carrying the lower risk of complications. However, when the arterial feeders of the choroidal malformation are too numerous, there are too many arteries, and the transarterial axis is obstructed and it cannot be achieved, transvenous embolization may be the only viable option. But if we're using the transarterial option, we can use the femoral artery or the radial artery. Hydrocephalus is the most common complication of VGAM, as per the climate literature, can arise during pre and postnatal development. The pathology can form due to hydrodynamic disorders associated with the VGAM or mechanical obstruction of the aqueduct of Sylvius by vascular mass. While in some cases endovascular embolization by itself resolves the VGAM and the hydrocephalus secondary, in other cases, due to clinical or financial concerns, as in the one in this case, regarding the embolization procedure, a complementary treatment is necessary. The option in this case is a ventriculoperitoneal shunt or endoscopic third ventriculostomy. Endoscopic third ventriculostomy is the recommended approach, as is associated with considerably lower rates of complications in neonates and infants, while being a relatively safe and widely practiced procedure, having a morbidity rate of around 2.38%, with the most common complications including postoperative fever, intraoperative bradycardia, and minor intracranial hemorrhages, with lower risks. Epilepsy is a common complication associated with intracranial arteriovenous malformations and cerebral cavernous malformations, with an incidence up to 50%. However, it is not observed as a comorbidity or a postoperative complications in VGAM embolization or the pathology itself for the lesion. We have found only one case in the literature that indicates that epilepsy is as a secondary pathology due to VGAM. However, in an adult patient, in neonates or infants, there are no cases or anything reported in the literature. Conclusion: VGAM is a rare congenital abnormality that can lead to poor or fatal outcomes if not treated properly. In neonates and infants, it is typically treated through transarterial endovascular embolization when it's accessible. In cases where obstructive hydrocephalus is secondary to VGAM and primary pathology cannot be treated, and endoscopic third ventriculostomy can provide good results. Epilepsy is not associated with VGAM or its treatment, with limited evidence in the literature that there are. A pediatric patient with VGAM and secondary obstructive hydrocephalus was treated first for secondary pathology via endoscopic third ventriculostomy and later for transarterial endovascular embolization for the malformation itself. The patient survived to 4 years with normal development before treatment, highlighting the need for further research of VGAM-related or embolization-related epilepsy. These are my references. And I want to thank you for your attention, and I'm open for questions.
Palmen Penchav, thank you for your nice presentation.